This is the explanation for the second ECG. This was the ECG that was sent out, and the answer choices are on the right, and in this case one or more of the answer choices could be correct. The purpose of this ECG is to diagnose these high voltages in the anterior and lateral leads combined with the ST elevations in the anterior leads and ST depressions in the lateral leads. In addition, there is also a slightly prolonged QRS complex. These answer choices were wrong because of the following reasons. Anterior Stemi was one of the choices that was given. As we talked about earlier in the first ECG explanation, all STEMIs, all ST elevation MIs are usually accompanied by reciprocal ST depressions in the opposite leads. So in this case, because there is anterior ST elevations, there should be inferior ST depressions if these were related to anterior STEMI, which you do not see there. Benign early repolarization, we talked about it in the first ECG. The ST elevations in this case are not diffuse because there is ST depressions in the lateral leads. Especially in the lateral leads, they are absent, as you can see here. There is also no J-point notching, which is usually seen with early repolarization. It is not a WPW because there is no delta waves, there is no PR shortening, although there is some increase in peak R wave time, which is the time from the onset of the QRS complex to the peak of the R wave. There is QRS widening, but the QRS duration is less than 120 milliseconds, and there is also S waves in V5 and V6, which goes against the diagnosis of left bundle branch block. Left atrial enlargement is not present in this case because the P wave duration in lead 2 is not more than 2 millimeters, and there is no hyper exaggerated negative waveform of the P wave in lead V1. In addition, it's not acute pericarditis, again because the ST elevation is not diffuse and there are no PR depressions. These four answer choices are correct. Sinus rhythm, because every P wave is followed by a QRS complex and every QRS complex is preceded by a P wave, as you can see on the ECG. Left axis deviation, left ventricular hypertrophy, and strain due to left ventricular hypertrophy, as we will talk about in the following slides. There are multiple methods to assess axis on a ECG. For all of them, we need to first figure out if the QRS complex is mostly negative, positive, or isoelectric. As you can see here in this QRS complex, the yellow part is positive, green is negative. There is more yellow than green, therefore this is a mostly positive QRS complex. In this QRS complex, there is more green than yellow, so it's a mostly negative QRS complex. And there is equal amounts of yellow and green in this QRS complex, so it's an isoelectric QRS complex. The most accurate way of assessing axis is by the isoelectric method, which is we need to figure out which of the limb leads has the most isoelectric QRS complex, which means there is equal amounts of negative and positive waveforms in the QRS complex. In the ECG that was given, AVR is the most isoelectric QRS complex, so you choose AVR on the axis diagram and then you go 90 degrees perpendicular to AVR in the direction of the most positive QRS complex among the limb leads. So in this ECG, AVL and lead 1 are the most positive, so you go perpendicular from AVR in the direction of AVL, which lands at minus 60 degrees, which is in the left axis deviation zone. So this ECG shows left axis deviation. The other approach is called the Quadrant Approach, where you can take lead 1, 2, and AVF, or in this case, you can just take lead 1 and 2. If lead 1 is positive and lead 2 is positive, it's a normal axis. If lead 1 is negative, if lead 2 is positive, it's a right axis deviation. Or in this case, in our EKG, lead 1 is positive and lead 2 is negative, which goes along with left axis deviation. To understand the EKG criteria for left ventricular hypertrophy, we need to understand the basic principles of ECG, which is the QRS denotes the depolarization, which is the activated state of the myocardium, and the ST and T waves represent the repolarization of the myocardium, which is the transition from an activated to a resting state. In order to understand depolarization and repolarization better, you need to understand the His-Purkinje system. The ventricular depolarization occurs by the spread of impulses through the His-Purkinje system. The initial portion of the His-Purkinje system, starting from the AV node, His bundle, and the right and left bundle branches, are insulated, and therefore the ventricular myocardium does not depolarize directly from the bundle branches. The initial depolarization of the ventricular myocardium starts from the His-Purkinje system, His-Purkinje fibers that comes off from the left bundle, and the depolarization spreads from the left towards the right side of the septum, and then starts to spread towards the apex of the ventricles, and then goes in the opposite direction, some towards the left ventricular lateral wall and the others towards the right ventricular lateral wall. To understand repolarization better, you need to understand the location of the Purkinje fibers within the myocardium. The His-Purkinje fibers are located in the subendocardial region, just below the endocardium, and the rest of the thickness of the myocardium is beyond that portion of the myocardium. Therefore, the depolarization occurs from the endocardial surface towards the epicardium, and repolarization occurs in the opposite direction from the epicardial surface towards the endocardium. This figure shows the activation of the ventricles through the His-Purkinje system. As you can see here, each of these numbers denote the time of activation from the onset of the QRS complex. As you can see here, the first part of the activation is in the middle part of the septum. You can see 10 milliseconds here from this figure, and as you go towards the apex, you can see the apex depolarizing next about 20 milliseconds, and then it spreads towards the left ventricle and the right ventricle, and you can see here the lateral wall depolarizes in about 30 milliseconds from the onset of the QRS complex, and then it spreads towards the basal portions of the ventricle, towards the left ventricular base and then towards the right ventricular base from the apex. Most of the electrical forces during depolarization undergo cancellation due to the opposing forces because they go in the opposite direction. And the QRS complex is therefore formed by the residual of the non-cancelled forces. So we're going to see this in the next figure. To understand the voltage criteria for left ventricular hypertrophy, you need to understand the formation of the QRS complex in the precordial leads. And if you look at the QRS complex, it basically consists of three parts. The first part, which is denoted here by this red arrow, is the septal depolarization, and as you can see here, it happens within the first 20 milliseconds of the onset of the QRS complex. So the septal depolarization goes anteriorly and towards the right, towards V1. And if you see the QRS complex in V1, that is denoted by this red portion of the QRS complex, which is a small R wave. That is because this waveform, this depolarization, comes towards V1, as you can see here. And this same waveform that is going towards V1, because it's going away from V5 and V6, it forms a small Q wave, a negative deflection in the QRS complex in V5. The second portion of the QRS complex is the apical depolarization, and most of it is carried towards the left ventricle because of the bulk of the left ventricular muscle, and therefore that depolarization goes leftward and posteriorly towards V5 and V6, and this happens between 20 and 60 milliseconds from the onset of the QRS complex. So this waveform goes towards V5 and V6, and therefore you have a large positive deflection in V5 and V6. So there's a large R wave in V5 and V6. That same depolarization that goes towards V5, because it's going away from V1, in V1 you can see a large S wave or a negative deflection in the QRS complex. The last portion of the QRS complex is formed by the depolarization of the basal parts of the ventricle, which is denoted by this yellow arrow here, which happens about 60 milliseconds or more after the onset of the QRS complex, which, because it's going away from V5, is seen as a small negative deflection or S wave in V5, and it's generally not seen by V1. As you can see here, this is the transition of the QRS complex from V1 to V6. As we saw before, V1 is a small R wave and a big negative S wave, and V6 is a small Q wave followed by R wave and then followed by a small negative deflection, which is the S wave. And there is generally a transition of the QRS complex from this morphology to this morphology between V1 and V6. Other than the precordial leads, the other three leads that are most important in the voltage criteria for left ventricular hypertrophy is lead 1, AVL, and lead 3. That is because lead 1 and AVL look at the net negative force that is going towards the left arm, left shoulder, or towards the left lateral part of the heart, and therefore left ventricular hypertrophy is best seen in lead 1 and lead AVL. In addition, lead 3 looks at the left arm from the opposite end of the spectrum, and therefore any forces that are going towards the left arm will be seen as a big negative deflection in lead 3, and therefore some of the voltage criteria for left ventricular hypertrophy also use lead 3, as you can see from the next slide. So here are the voltage criteria for left ventricular hypertrophy that is most commonly used. Most of us use Sokolov-Lyon criteria or the Cornell criteria. Most of these criteria are based on the fact that when the left ventricular muscle hypertrophies, the big bulk of the left ventricle draws more voltage towards V5 and V6, as we talked about before. So therefore there is a big R wave in V5 and V6, and because that bulk of the left ventricle is going away from V1, you have a big negative deflection in V1. As you can see here, there is a big large S wave in V1 and a very large R wave in V6. So using that, they have come up with several different criteria, as you can see here. As long as you know the general principle of left ventricular hypertrophy voltage criteria, which is basically large S waves in V1 and large R waves in V6, in addition to sometimes seeing large R waves in lead 1 as well. You can always look up these criteria on Google or just search for them. But in general, each of these have different sensitivity and specificity. As the sensitivity kind of improves, the specificity decreases, and as the specificity improves, the sensitivity decreases with these criteria. In the EKG that was given to us, there are more than one of these voltage criteria that are positive, and therefore we do have left ventricular hypertrophy by voltage. In addition to left ventricular hypertrophy with voltage, many people look at other criteria for LVH, which includes these repolarization abnormalities in LVH. So I have given two explanations for why you see repolarization abnormalities, which is the ST depression and T wave inversion on these EKGs with severe left ventricular hypertrophy. One of them is an electrical explanation, the other one is a structural explanation. The electrical explanation: when you have depolarization, your endocardial action potentials are much wider than the epicardial action potentials, and so therefore, even though the endocardium starts to depolarize first, the epicardial myocardial cells actually starts to repolarize first, and therefore the repolarization, as I told you before, goes from the epicardium towards the endocardium. When you have left ventricular hypertrophy, there is so much time that it takes for the myocardium to depolarize from the endocardial surface towards the epicardial surface that the Repolarization also occurs in the same direction from the endocardium to the epicardium, therefore causing ST and T wave changes. In addition, there might be some relative ischemia or demand ischemia to the myocardium. As multiple studies have shown, there is decreased coronary flow reserve in patients with left ventricular hypertrophy. In addition, as you can see here, the myocardial blood flow generally goes from the epicardial surface towards the endocardium and decreases in the amount as it goes towards the endocardium. And so when you are having a much more hypertrophied left ventricle, there might be some relative ischemia to the myocardium. All these manifest itself as ST-T wave changes on the ECG, which is called the strain pattern. In general, the most pronounced ST-T wave changes happen in the same leads where the amplitude of the QRS complex is the highest. So therefore, you will see these in V1 and V2 and V5 and V6. In general, again, the ST-T wave changes occur in the direction that is opposite to the terminal force of the QRS complex. So as you can see here, this QRS complex ends with a big S wave, and therefore there will be an ST elevation in V1 and V2. And if you go towards V5 and V6, as the terminal force of the QRS complex is positive, so the last part of the QRS complex is positive, you will see ST depression and T wave inversion in these leads. In addition to being a diagnostic criteria, LVH with strain pattern can also be a prognostic criteria. Most patients with LVH with strain have a higher mortality rate and higher rate of complications and heart failure. We have discussed three different criteria for left ventricular hypertrophy. Number one is left axis deviation. Number two is left ventricular hypertrophy criteria by voltage. Number three is repolarization abnormalities called LVH strain. And the fourth criteria is this, which is R wave peak time. R wave peak time is usually measured in leads AVL, V5 or V6. It is measured from the onset of the QRS complex to the peak of the R wave. If the R wave peak time is more than 45 milliseconds, it generally denotes delay in conduction in the ventricle, just because the muscle is so thick it takes longer to depolarize the muscle, and therefore the R wave peak time becomes more than 45 milliseconds. In general, this also causes QRS prolongation. In our patient's EKG, the QRS is prolonged not more than 120 milliseconds, but less than 120 milliseconds, close to 110 milliseconds. That is due to left ventricular hypertrophy, where the conduction is delayed. In patients with left ventricular hypertrophy that have progression of the disease, you can see almost a 6 millisecond prolongation of the QRS complex each year. See you next week with another ECG.